Okay, how does a private specialist treat a patient with suspected tick-borne infections? Well, the easy part of this is if you catch somebody early with Lyme disease, the standard treatment works most of the time. So the standard treatment for Lyme disease, according to the most recent guidelines, is to treat with 3 weeks of antibiotics. And if patients are responding but not better, then switch to a second antibiotic. And the usual guidance is 3 weeks of doxycycline, and then switch to amoxicillin. You can find this within your national guidelines. So this is the easy part. You have somebody with a tick bite, you have somebody with a fever, you have somebody with a rash, you treat them. And if they don't get better, then you go another 3 weeks. The challenge is patients who are not that simple, who show up 6 months later, where the diagnosis of Lyme was not made, or they had a rash and somebody said, well, let's wait for the antibody test to come back, and the antibody test was negative. You shouldn't wait, you should treat. But I'm seeing people who were not treated, or people who were given topical creams for a fungal infection following a tick bite, or put on flucloxacillin for a cellulitis when it was a tick bite, and Borrelia does not respond to flucloxacillin. So what do you do when somebody's had dissemination of the bacteria to all of the different organs of the body that we know Lyme spreads to? Is there still persistent infection? Absolutely. Will 3 weeks of antibiotics or 6 weeks of antibiotics work? Well, the answer is no, not always. We know already that for those who are adequately treated, there's a condition called PTLDS, post-treatment Lyme disease syndrome. These are people who are caught in the acute setting. 20% of them are still sick. My observation is they need longer course antibiotics, just like I do for any other infectious disease condition in the world. But for some reason, we can't do this for Lyme. The second issue is what if they don't have Lyme, but they have another infection similar to Lyme? These are called co-infections. And co-infections in Ireland consist of Anaplasma, Rickettsia, Babesia. The textbooks say that animals get these infections, but humans don't. But the reality is, I think these infections are underreported. So very often, I think private specialists who are managing Lyme outside of the NHS will treat patients with combination antibiotics to cover not just Lyme, but the co-infections, and will treat people until they get better. And indeed, international guidelines recommend, for example, the French guidelines recommend treating patients until they get better. Just like I treat patients with other infectious diseases until they get better. I don't stop arbitrarily when they're still sick or improving on antibiotics and say, Bob's your uncle, you've had the treatment, still sick, too bad, must be post-infectious. So the reality is this is an unkind thing to do to patients, not based on good science, and many studies have shown persistent infection even after standard treatment in research studies. So I think the guidance really should be that we treat patients, not guidelines. And we should learn from our patients and listen to our patients. And there will be new guidelines coming out someday in the future when the appropriate, well-controlled, studies are done. But you can't do these studies when there's such a denial about this condition, chronic Lyme disease, and the co-infections that go along with that. And indeed, these are infectious diseases, not post-infectious conditions, not viral infections. And I think we need to learn more about these diseases and work with the patients and learn from our experience as clinicians, and listen both to the specialists who are managing these patients and listen to the patients who are living with these conditions.